So good morning to everybody. There's a large group today, no pressure or anything. So we decided to talk about pain management because it seems to be kind of the last point of contention sometimes between the two agencies. And there's no right or wrong answer with a lot of things in medicine, and I harp on this over and over again. It's a gray area. There's no right or wrong answer. It's a bit of a difficult presentation to put together to try to make it semi-interesting because there's a lot of pharmacokinetics that we're going to review. It's nothing that should be earth-shattering or that you shouldn't know already. But then at the end we have 3 cases that we'll kind of just talk through as a group and how different people would handle it, different ideas on the cases, and hopefully that's where the most useful part of the presentation will come, just because we have a good showing kind of from both agencies in 2 different perspectives. So what we're going to do is we're going to talk about the background of pain management. Why do we care? We're going to talk about the methods of pain management, the different medications, documentation, and then the cases. So why do we care? So 15% of all EMS calls have a primary complaint of pain. Doesn't seem like a lot. I thought it was going to be a lot higher, but when you look at the national research, it's only 15%. But 65% of them have pain as a component of that complaint. So it might not be their primary complaint, but it's a secondary complaint, or it's a going along with their primary complaint. Poor pain management increases chronic pain, PTSD, depression, and length of hospital admissions. Length of hospital admissions was up to 4 days longer with inadequate pre-hospital pain management, which I thought was pretty significant. I would not have guessed that. So different methods of pain management. We always want to start with the basics. Just like any cardiac arrest, we want to start with good BLS. Same with pain management. So we want to start with distraction with conversation. This has been proven to reduce the majority of the pain in the pain studies that they've done in the pre-hospital setting. So this is, talking to the patient about things other than what is acutely going on with them, distracting them with it. And anytime you're going to move them or do anything with them, then using advanced explanation. Tell them ahead of time, okay, this is what we're going to do, and it's going to be uncomfortable, but after that we're going to be done. And it sets the expectations of what's about to happen. Then the basics that we all know: elevation, cold pack, splinting, and keeping parents around with kids. And that's even in the teenage group. Just having the parents around can reduce the anxiety of having a bunch of people in uniform swarming around them. They're not sure, what is going to be happening to them. They've never been in an ambulance before. They've never gone to the ER before. It produces a lot of anxiety, and keeping the parents around with them can really help reduce that, and therefore reduce their pain as well. And then the medications, the main ones, morphine and fentanyl, and we'll talk a bit more about those. So the most important thing from my perspective is setting realistic expectations. We're not going to make the pain go completely away. The goal is to make transport and movement tolerable. And even some of that, by giving pain management, still the initial movement from their position up to the cot is not going to be so much as tolerable, but what we want to do is take the edge off. We don't want to snow them so that they don't feel anything, because once we take away that pain stimulus, then they're going to have a lot of medication on board. They're not going to have that arousal from the pain, and they're going to have respiratory depression. So again, explaining to them, this medication I'm going to give you isn't going to take your pain away. It's going to hopefully make it a little more comfortable when we move you. And if we need to give you more, we certainly can do that. But we're going to start with a small dose. And then repositioning is a major thing I think that gets overlooked. So a lot of times, just by repositioning someone on the cot, or the elderly person with a hip fracture who's on the floor, just getting them up off of that hard surface onto the softer cot can help a lot with pain management, and a lot of these people don't even need narcotic medications. So we're going to talk a little bit about morphine. We all know it's an opiate. Onset is 5 to 10 minutes, but the peak isn't until 15 minutes. So in our protocols you can redose every 5 to 10 minutes. So we're actually redosing before we're hitting our peak, which is a dangerous thing, because then you start to get dose stacking and you're going to increase your risk of respiratory depression. Duration of effect is 3 to 4 hours, so it's longer acting. It's mostly metabolized through the liver, so that comes important in our chronic liver patients, our cirrhosis, our long-standing alcoholics who we know have underlying liver disease. They are going to not metabolize this, so they're going to have an increased duration of effect as well as an increased peak of effect. It's excreted through the kidneys, and the side effects we all know are mostly due to histamine release. So you're going to get some bradycardia, hypotension, respiratory depression, some itching, nausea, urinary retention. All these happen in greater than 10% of cases. So if you pull up the side effects of morphine, it's literally like an 8-page document. But these are the most common ones. They happen, again, in more than 10% of the cases, which is a significant amount of patients that you're treating. And again, most of them are from the histamine effect. Pregnancy, it's class C, so what that means is in animal studies, they found that sometimes it had adverse effect on animals. So it's not recommended in pregnancy, but if you need to use it, you can. They recommend if you're, gonna give it close to someone delivering, that baby's gonna come out with some potential respiratory depression, so keep that in mind and be ready for some airway and support and intervention. And it does enter the breast milk, so it's important to know, so when you have young mothers and you need some pain management for some reason, it's important to ask if they're breastfeeding and let them know, hey, this pain medicine, it does come through your breast milk, so just, you either want to pump or be aware that your baby's going to be a little more sleepy. Which isn't always a bad thing, right? Yeah. So our current dosing, IVIO-IM, is 2 to 5 milligrams every 5 to 10 minutes. Again, this is giving a repeat dose before our peak effect. So this will be changing in the new protocols. It'll be every 15 minutes because we don't want to get dose stacking with our narcotics. Max for 20 milligrams is severe pain and 10 for ischemic chest pain. PEDS, you can see the dosing 0.1 mg per kg. And then it's called Driving Miss Emma on the street. The street name of morphine, if you're high on morphine, it's called Driving Miss Emma. So I always thought that was entertaining that you guys are driving Miss Emma. So the special populations, again, the renal impairment, because it's excreted through the kidneys. If someone is on hemodialysis, this is going to stay around in their system longer. It has a little bit less of the active substance because a lot of it's been broken down by the liver, but they still will have a prolonged effect. And then our chronic cirrhosis and our chronic hepatic patients, you want to reduce the dose by 50% because they're unable to metabolize it. So they're going to, again, have higher peak effect and longer duration. Now, it's a little bit different in someone who has like acute hepatitis, flare, or hepatitis A. They're going to have other ways of metabolizing this drug, so it doesn't necessarily apply in the acute hepatic injured patient, but it's more of our chronic liver patients. And the NSTEMIs you want to be a little bit careful with. Anybody that you're concerned about cardiac ischemia, there was the CRUSADE study. It had over 17,000 patients in it. It's a very large study. It was done well, and it showed up to 20% increase in mortality from giving morphine with NSTEMIs. So it's kind of controversial in the medical field on whether or not you should be giving morphine to your cardiac patients or patients you're concerned for acute ischemia because of the increased mortality. And then you want to be careful in the elderly again because it tends to affect a more longer duration. Side effects makes them dizzy. They're higher risk for falls. Any questions on morphine? Fentanyl. So we know it's a synthetic opioid. Its onset IV is immediate and intranasal is 5 to 15 minutes, and it peaks in 2 to 3 minutes. So it's very different from the morphine where it peaks in 15 minutes. This is on suddenly, fast peak, and a shorter duration. So 30 minutes to an hour. It again is metabolized through the liver, it's excreted through the kidneys. Side effects: bradycardia, respiratory depression, chest wall rigidity, and nausea. The chest wall rigidity is with a fast push and higher doses. As Ted and I were talking about, it is debated on whether or not it actually exists in the literature, but I can tell you I've had a case of it, and I truly do believe in it, and it's scary, and it's very difficult to beg someone through it. So again, this is when you're pushing it fast and you're pushing high doses, typically in procedural sedation, but it is something to keep in mind in the pre-hospital setting as well. It's also higher in pediatric population. Pregnancy class C, so again, need to be careful. It does have has had some proven poor outcomes in animal studies, and it does enter the breast milk. So here's our current dosing, 20 to 50 micrograms every 5 to 10 minutes. So again, we're past that peak effect, so we're not stacking doses with our current fentanyl protocol. PEDS, 1 microgram per kilogram, and again, the slow push over 1 to 2 minutes to help reduce the risk of any respiratory depression and chest wall rigidity. So fentanyl special populations, because it is metabolized just slightly different than morphine, you actually don't have to reduce your dosing in our liver patients or our renal patients. So even though it still is metabolized by the liver and excreted through the kidneys, it has some things outside of those systems that help compensate if those systems are compromised. So it's an easy one not to have to remember, okay, I need to reduce the dose because this patient is a chronic cirrhotic. It does have an increased respiratory depression in our hypercapnic patients, our chronic COPDers, someone who's on O2 chronically, or people who wear CPAP at night. They're typically chronically hypercarbic, and it does have a little bit of an increased risk of respiratory depression, although it is pretty minimal. It's less than 2% when you look at the true literature. And elderly, twice as sensitive to it, same thing as morphine. Increased delirium and dizziness, risk of falls, unsteady gait, all that kind of good stuff. So I wanted to talk a little bit about Suboxone because it's becoming more prevalent in the community. It's a partial agonist and antagonist of the mu receptor, so that's the receptor that all of our opioids work at. So it's going to be blocking as well as stimulating. And the goal that it's mostly used for is for chronic opiate-dependent patients. It's also starting to be used more for chronic pain because it does stimulate that same receptor that our opioids are stimulating. But because it binds to that receptor with more affinity than any of our opioids, if someone's on Suboxone and then you push fentanyl or morphine, they're going to have essentially no effect from it. So it's something, when I see patients in the ER and they're on Suboxone and they're having pain, I can say, hey, look, I can give you all of the pain medicine I have in the ER, and it's not going to help you because your medicine is stronger than what I have. And they seem to understand that, but you have to, again, set those realistic expectations. I still try to give them some medicine and see if it doesn't help take the edge off, but you're setting that expectation that, hey, this may or may not work, and it's probably not going to work a lot, so that you guys are both starting from the same page. And then in the pill form, it's mixed with naloxone so that people can't crush it up and inject it. So they actually go through pretty good withdrawals if they try to inject it, which I thought was actually smart thinking on the manufacturer side. Any questions on Suboxone? This has to be prescribed by a special provider. It has a special licensing to your DEA form, so only certain providers in the Valley can prescribe this. Isn't anything that they can get out of the ER from their primary care doctors. It's given a lot through the methadone clinics and drug addiction physicians, as well as chronic pain physicians. So a little bit about opioid withdrawal, because we have had a few cases in the pre-hospital setting where, okay, what do we do with this? Like, do we give the patient a little bit of narcotics to help take the edge of the withdrawal off, or do we not? So you guys can also help to tell your patients, because a lot of times they say, hey, I'm trying to wean off my methadone. How long are these symptoms going to last? So the common withdrawal symptoms are your nausea, vomiting, diarrhea. They get very restless. They yawn. They get lacrimation, mydriasis. They get cold flashes with goosebumps. That's why they say going cold turkey, because you get the little goosebumps like a turkey. And then you get this spontaneous kicking of the legs, and that's how I got the term kicking the bucket. It's rarely life-threatening, unlike alcohol withdrawal, which can be life-threatening. Opioid withdrawal is not life-threatening. It totally sucks, and it takes a long time, and they feel miserable, but it's not life-threatening. Peak symptoms are in 48 to 96 hours. That is with methadone as well. The peak symptoms tend to be more on the 96-hour side, but it does peak within the same time frame. And the resolution of symptoms is 8 to 12 days. Methadone can last up to 15 days, so it's a little bit longer. A little bit about the benzos, because I know a lot of people like to push benzos with narcotics, especially for hip fractures where you're having a lot of muscle spasms. So we wanted to review these. Now all of these can accumulate in the fat tissue. So there's something, it's not as much of a deal in the pre-hospital setting because you're giving a dose or two, but if someone is receiving multiple doses for days on end, it can accumulate in the fat tissue. When you stop giving that, that patient's still going to have the effects from the benzodiazepine. So Ativan has the greatest potency. It has the longest duration of all the three that we have within the system. It has the slowest onset of action. Valium has the fastest and the shortest duration, but there's a national shortage, and I don't think anybody has it on their trucks currently because we haven't been able to order it for about the past year. Most of us are using Versed. That's what I see on the majority of the charts. Onset of action is 2 to 5 minutes, and it's a short duration, so it's a really good one. We use it a lot with cardioversions as well as pacing because it gets that amnestic effect as well, which is really nice when you're kicking someone in the chest with a big jewel. So opiates and benzos together, not my favorite thing in the field, again, because it's procedural sedation. I know that a lot of you would love to be doing procedural sedation in the field, but it does take special training, special requirements, and special CMEs to keep it up. Studies vary, but up to 30% of increased risk of significant airway management. So that's not just a little BBM for a couple of minutes. This is supraglottic airway or an intubation or prolonged BBM with an oral airway. So these are not, little itty bitty things where they desat for a couple of minutes. Again, it's considered procedural sedation. And benzos increase delirium in the elderly. So a lot of times people say, oh, they're having an adverse reaction to it, let's give them some more. Well, more doesn't help. More actually increases their delirium, their agitation. And it's, again, found mostly in the elderly as well as the critically ill. We see it a lot in the ICU patients, but it's something to keep in mind. In our elderly population, if you give them the medication and they have an adverse effect to it, they become agitated or aggressive, giving them more is not going to help. It's going to make the situation worse. So documentation, very important with pain management. Pain is our 5th vital sign. We need to get all of our vital signs before we are giving pain management. So there's many charts I see where the patient has been given a dose of a medicine and then 2 minutes later is their first set of vital signs. Absolutely not acceptable. These patients need vital signs first because they need to make sure that they're hemodynamically stable and appropriate candidates for receiving this pain medicine. You want a report on with the numeric rating scale, which is our 1 to 10, where's your pain? So that after you give them the medication, you could say, okay, on that scale again of 1 to 10, where are we now? That's documenting your response to an intervention by documenting that recurrent pain scale. Mental status assessment, especially on our trauma patients, you want to see if they were alert and oriented to person, place, time, and event before you put this on board, or was that confusion that they now have after receiving narcotics, was that there before and more concern for underlying injury, or did that come after some medication? You want to write the tactics used. That goes back to our basics. Did you use distraction? Did you use good splinting? Did you put an ice pack on the fractured ankle? Did you elevate it? Did you pad it? All that kind of good stuff. You want to, again, go back to the basics first and make sure that you're documenting it. You want to do your dose and route, and when you're starting these IVs, it's important to document that you flushed it and there was no signs of any infiltration, that it had a good flush, no signs that it had good flow. Something that says that this medication, that it was a good IV start, so if you get some extravasation and they have some tissue damage around the site, which can happen more often with morphine than fentanyl, then you have documented that your IV was good and it was a good start with no complications. This is really important when you guys are pushing dextrose too, because it's highly toxic to the tissues. It's really, really important that you're documenting a good IV start. So if there is a complication, you can go back and say, look, this is where I started. This is my IV start. It flushed well. There's no signs of any extravasation. This was a good IV. And then again, our response to treatment can be documented just by repeating the pain scale. Doesn't have to be anything elaborate, just a simple change in the number. Did it work? Did it not work? And then monitoring after administration, we want to make sure and have at least a pulse ox on them so we can see for any hypoxia as well as heart rate. And we want to be reassessing their mental status, examine their ability to protect their airway. Questions on documentation? You guys bored yet? So case number 1. So dispatch to a back pain, 34-year-old male with history of back pain states, my pain meds aren't working. So what do you guys want to get for history from the patient?
What kind of pain meds is he taking?
Okay, what kind of pain meds is he on?
What elicited this call?
What?
Why did he call us for this specifically? Would he do something different? Is it acute on top of a chronic, or is it just chronic and.
Right. Was he having an acute flare? Did he do some, everybody with chronic back pain loves to move furniture. Did he move furniture recently? Did something flare it? What else do you guys want to know in the history? How what?
How long has the pain been going on?
How long?
Is it?
On a scale of 1 to 10, what is it? Great. What else? What are some red flags with back pain that would be good, pertinent, positives or negatives to put in your history?
Neuro assessment.
Neuro assessment? What else?
Can you make it better or worse?
Alleviating aggravating factors? What else?
Describe the type of pain.
Type of pain? Sharp, dull, burning,
Where in the back?
shooting.
Where it hurts in the back, is it more like flank or is it actually it's fine?
Yep. Where on the back? Is it lateral? Is it midline? Does it radiate? What about changes in bowel or bladder? Okay. What about weakness? Those are the three major things with back pain that are kind of the big red flags, especially in someone who has chronic back pain. Because that tells us that, hey, there's something pretty serious going on. They need an MRI right away and potentially a surgical intervention. So we talked about, a little bit about our pain scale, our neuro assessment. You'd look at their back, where is it? Have them point to it, palpate the midline, check for tenderness in the flanks. Have they been having any urinary symptoms? Is this someone who has chronic back pain, but now they have a kidney stone or a pyelonephritis or something else that's flaring their back pain that's giving them a back pain, and they think it's a flare of their chronic back pain, but really it's another pathology going on. So what would you guys do with this patient? Say it's a flare of his acute back pain, it's midline, radiates down the right leg, he has no change in bowel or bladder, there's no weakness in the leg, he's able to get up and walk around, although he appears uncomfortable when doing it, and there's no evidence of any trauma or rash when you look on his back.
So what kind of pain management has he had? Has it worked in the past? Any changing?
Okay, say he's on 2 milligrams of PO Dilaudid at home with Norcos for breakthrough.
How quick does he go?
I was gonna say, how is it taking the or is he out 10 days into the script?
Right, is he out of his meds and he went out early and can't get it refilled and that's why he's calling you guys? Or is it that he has been taking his Norco or Percocet like candy and now has a potential for overdosing on his Tylenol? Would you put an IV and give this guy pain medicine?
Nope.
Nope?
He's able to walk around, he's relatively uncomfortable but doable. I tried to talk him into going to the hospital on his own, saving the bill.
Okay.
Give him ice pack.
Give him an ice pack? Yeah.
Nice day.
So would anybody give this guy narcotics? Alfred?
Yeah,
Okay. Why?
because he's in pain.
Okay.
It's not my job to say, I'm there to evaluate, but if he's complaining of pain, I'd start him off with 2 morphine.
Do you think that he needs it acutely in the pre-hospital setting, or do you think that he could go in for evaluation and get some pain medicine there potentially?
Either one, but he called us, so he's probably got Medicaid, probably wanting a free ride, so.
Okay.
Change on presentation, I mean, if he
It's not
if he appears to need some more pain medication, I mean, sure, but based on what you gave us initially, in my opinion, if he's like walking around, it could go either way. It's hard to say just from discussion.
Yep, and there's no right answer. I'm not calling anyone out right or wrong. These are the tricky patients where this is acute on chronic without any red flags for, worrisome stuff, and there is known chronic pain medication. So the doses we're giving are most likely not going to be helping these individuals who are taking high doses of pain medication at home. I don't in any way mean to stereotype or offend anyone, but a majority of these people are on pain contracts with their primary care physicians, and majority of them also have pain contracts with the ER. So we can actually flag people's charts and put them on a pain contract and state that they will absolutely not receive any narcotics or benzos on further ER visits. So it's something to be aware of because these patients will call you all the time. If they get what they need and what they like, they will call you all the time. Now, is that meaning this patient should stay at home and in pain and you should refuse to transport them? Absolutely not. But be leery of giving them benzos or opiates in the pre-hospital setting, especially if there is not an acute trauma or something that you're concerned about medically from your history or physical exam. The patient does not need the pain medicine right away within the first 20 minutes. They can, reposition, ice packs, distraction, all of your basic techniques during transport can be seen in the ER and then be determined if they need pain medicine and go from there.
Understanding a pain contract too, it's not just that, like you guys may use it, that they can't have any meds. It's a pain contract with a pain doctor is a contract. And it says, I will do this stuff and I won't do this stuff. It doesn't mean, oh my gosh, I will never give them pain meds.
Right, so a pain contract, especially with the primary care physicians and the pain management physicians, the pain contracts mean that they won't shop physicians and they won't shop ERs
Right.
for narcotics or benzos or controlled substances. But that doesn't
That
mean...
doesn't mean pre-hospital. They're not shopping. They have an acute problem. And if anyone's had chronic pain, they understand that.
Right. And that doesn't mean that we won't give it to them in the ER. It just means their doctors know, and all of our dictations go to them, that they had an acute on chronic flare and that we are able to treat them without them breaking their contract. Yep. But it's just something, these are the cases that are gray. There's tons of different opinions. There's no right answers. Everybody's personal background for either them or their family brings an influence to a case like this. But just what I'm asking is stop and think about it. Don't rush in the door, give 100 of intranasal fentanyl, and be on your way. This is someone you need to stop and think about and make a decision as a team because both agencies are going to be on scene so that everyone's on board. Other questions, comments?
Hey, Carrie, just in this same type of venue, I guess. I noticed maybe about 6 months ago at all the St. Luke's and all the St. Al's facilities and the ERs, they put up plaques on the wall that says, like, we will not medicate chronic pain unless it's cancer related and blah, blah, blah. Can you speak to that? Did you guys get together with EMI and say, hey, it's what we're gonna do? Or
Yep, so we noticed that there was a decent population who was bouncing back and forth between ERs because they knew our systems didn't communicate. So our two groups got together as well as the hospital administrators and we said, okay, how can we better treat these patients? Because continuing to treat inappropriately their pain and not be followed by a primary care physician does not help them in the long run. And so we came up with essentially a pain management understanding so that as soon as they came in, they understood the expectations. So again, everyone was on the same page. They knew what we were willing to do. They knew what they could get versus not get, and it kind of set the expectations. Those have since come down because of some legal issue stuff, but we do a medical screening exam now, and then we give them the pain management, I can't remember what it's called, the underlying policy, so that they have it in the future, and we document in their chart that they received it, because a lot of times they'll say, oh, I didn't know about it, no, I didn't just come from Luke's and they have their band on, that kind of thing. So that's why it did come. EMI and IEP were trying to work together to reduce the abuse of narcotics within the valley.
what were those guidelines? Because I can't remember what they all said.
They were chronic pain, excluding cancer pain, and it also said that if they were on a pain contract, that while we could treat acute flares, it was at the discretion of the ER physician, and that they would be provided a medical screening exam prior to any dispensing of medication. They're pretty vague.
Does that screening exam include calling Luke's? Because we just had a patient that did that. We took him to Luke's. They didn't get anything. He walked off and called 911. Our ambulance transported him again to Al's. How do you know?
The ERs talk frequently, so we can call over and say, hey, can you get records from Luke's? We can also, the Idaho Board of Pharmacy has a prescription monitoring program that all the physicians have logins for. So I can get online and look up where someone's been filling their prescriptions, how often, how much, And you can clearly see when someone's been ER shopping, because you recognize all the ER physicians, and no one gives more than 20 tabs. So you look at the quantity, you look at the name, and you say, okay, this patient filled 3 prescriptions in one day from 3 different ERs. Like, that's a red flag. And so it's usually about a week to 2 weeks delayed. So if I see a pattern when I pull their history, then I'll call around to the ERs and see if they've been there recently or when their most recent prescription was given out. Now, all the Luke system communicates, so we only have to call one ER to Luke's to get all their information. So it's really 2 phone calls because we're already within the AL system. It's a call to West Valley and it's a call to Luke's, and you have every ER in the Valley covered. Cool.
So you're saying you have a lot more resources to figure this out than
Yeah.
than we would.
Exactly. Yep. Other comments, questions? All right, the favorite. Grandma fell down. So elderly fall victim, 88-year-old female, mechanical fall in the bathroom. Patient found lying wedged between the toilet and the bathtub in a small bathroom. What do you want to know?
What caused her to fall?
Right, what caused her to fall? Was she drunk? Grandma hit the margaritas again.
It's the holiday season.
Right, you want to know what caused her to fall, right? Did she trip on a rug? Did she get dizzy while she was having a bowel movement, which is very common for elderly people to have that vasovagal response with urination or defecation? So did she get dizzy when she did that and then she stood up real quick and had a fall? Did she have chest pain and shortness of breath and fall down? Did she have a syncopal event that she doesn't remember? All are very important, especially in the elderly or any fall victim in general. What else do you guys want to know?
C-spine precautions?
C-spine precautions? Would you automatically put her in them?
No.
Okay. What would help you determine if you did or did not?
If she was drunk or not.
She was drunk? Yeah. Is she hurt?
Just a physical assessment.
Okay, physical assessment, so you're gonna palpate midline. Okay, what else? Say she's complaining of some left hip pain. Huh? Pain scale? Yep, where is she on pain 1 to 10? What else are you gonna do? How long has she been there?
Where are vitals?
What are her vitals? Yeah. Exactly. So where are you gonna see what her blood pressure is, what her heart rate is? Make sure she's not already hypoxic.
Sugar.
Check her sugar.
How long has she been down?
How long has she been down?
Covered.
Is there obvious?
It's okay, Ted. We'll get you here. Don't worry. Is she what?
I said, is there an obvious deformity?
Is there an obvious deformity? So say there's an obvious deformity. Her right leg is shortened and externally rotated. She's complaining of 10 out of 10 pain. You check her blood pressure. It's, she's a little old grandma, so she's, 112 over 72, setting 98%. Had an obvious mechanical fall where she tripped on the rug as she was trying to get out of the bathroom. Didn't hit her head, didn't lose consciousness, no C-spine pain. Did you put her in C-collar?
No. Distracting injury.
Distracting injury in an elderly patient who falls.
And she's drunk.
And I would put this patient in a C-collar, even if she didn't have any midline C-spine tenderness, because she technically has a distracting injury, and the elderly at higher risk for vertebral injuries, even with a ground level fall. What do you guys want to do for her next? So she's still wedged between the bathroom and the toilet. We have a set of vital signs. 10 out of 10 pain. What do you guys want to do? Reposition her. Say it's a real tight bathroom. It's going to be a lot of movement to get her out from between the tub and the toilet.
Probably glad medicated.
See how she tolerates the movement.
What?
See how she tolerates movement first.
Okay, so you'll try to move her, see how she does. See how easily you can get staff in there to move her safely for your backs.
I'd go over a plan with her. I would ask her, I'd let her know that we need to move her, if there's going to be pain involved. I'm going to give her the option if she wants some pain medication before I move her, if she has an obvious hip deformity.
Yeah, and I think that's awesome. Have that conversation with the patient, set a plan with them, and with that you're going to set realistic expectations, right? I can give you some medicine before we move you if you like. It's not going to take the pain away when we move you, but it may take the edge off. Or we can try and move you and see how you do, and we can always stop and give you some medication then, right? It's setting a course, it's setting expectation, and it's establishing that communication with the patient, which is always good with customer service, which, like it or not, is part of our job. So, say she wants to try to move, declines pain medicine right away, you try to move her, it's too excruciating. What do you guys want to do? Huh? Take the toilet out? Who's gonna medicate her?
Dave.
Yeah, yeah, okay.
Okay, yeah. And what are you guys gonna give her? Iron fentanyl?
IV.
I would do IV.
IV?
Margarita.
Okay. I'm gonna get you a blender. So I hear some IV, I hear some IN. It kind of depends on the situation, right? Like if you can get an IV and she's doing okay in the position that she's in, and you see a good vein and you think you can get that easily, I think IV is gonna be the better choice for this patient. You're gonna get better pain control with an obviously painful movement. But if you're wedged in a teeny tiny bathroom, it's hard to move her, her arms are all kinked underneath her, you can't get an IV, I think iron fentanyl is a great choice. How much iron fentanyl would you guys give? See, she has a history of diabetes and hypothyroidism. That's it. No allergies. 50? 50 IN? No, I think that's a reasonable choice in an 88-year-old. I'd be a little hesitant to go as high as 100 on a single dose in an 88-year-old grandma who's a small body mass. Don't forget, she doesn't have any underlying kidney or liver disease. We don't need to reduce more or fentanyl for those patients, but it's a good thing to keep in mind. Who would give morphine on this patient? Good. That's good. I think fentanyl works better. Fentanyl, you have a faster onset. Your peak's going to be within 2 to 5 minutes, where morphine, your peak's not going to be for 15 minutes. So you're going to be moving that patient before you have your peak effect of medication. You're not going to have good pain control when you go to move her. So you give her 50 IN of fentanyl. She feels a little bit better. You get her out of the bathroom. What are you going to use to extricate her? So you get her flat on the floor in the bathroom. What do you guys want to use to extricate her up to the cot? Scoop. Good. Okay. And then what are you going to do with the scoop when you put her on the cot? Take her off. That's right. Okay. And then, obviously, get an IV established at that point, and you can redose her with some IV pain medicine as needed. Questions or comments on our elderly fall? Yeah, Jordy.
She's like really entangled. I mean, are you totally against like move her set on something like that?
With her,
Having to move her or rotate her if she
with her fentanyl?
Yeah, even with.
Yeah, I would be totally against that. The reason being is that she's 88. She's high risk for respiratory depression. You're in a wedged in space where if she does need airway management, it is going to be very, very difficult.
Okay.
And so I would be very concerned about pushing benzos with narcotics on that patient. Dave.
In the past, whenever I've done that, I'd low dose everything. I'd give her 20 of fentanyl and 0.5 or 1 of Versed and see what that did.
Yeah, I mean, again, you have to be cautious with using benzos and opiates. And I know that you like to use them together, and I'm not against it. We don't say in the protocols, absolutely, you cannot do this. But what I tend to see is the same dosing of both medications given together. And that's what scares the bejeebies out of me. So,
Me too.
So I think, again, I still would be cautious with this patient who is in a very difficult area if you have to do any airway management. Now, if you can get her from out of that toilet in the tub, and then she's in a more alignment, someone can stand in the tub and, take care of airway stuff if you need to, then it wouldn't be as big of a deal. But someone who is wedged in, on their side, all crooked, that's going to be really difficult to support their airway if you need to. Is that clear as mud? Yeah? Yeah.
What's your thoughts on a blanket split for these hip fractures?
You mean like a pelvic binder?
Mm-hmm. You wrap a blanket around the hip and then tighten it down and tape it down.
You're not really going to be hurting anything, although the majority of time that I've seen those, I have seen that it actually increases their pain. It might help stabilize them a little bit as you're trying to do the initial movement, But again, it's setting that realistic expectation of, hey, I'm gonna put this on so it hopefully reduces the movement as we get you out of here, but it's gonna be a little painful when I put it on. You're not gonna hurt anything by doing it as long as you're not ratcheting it down really tight, 'cause if they have those intertrochanteric hip fractures, you can actually dislodge it, the actual surgical neck of the femur, in more into the acetabulum. So you don't want to wrench it down tight, but it can help stabilize it when you're moving. Other questions, comments? This is probably the case where I hear the most provider frustration between the agencies. So while there's not a right answer, the one thing I do expect is you guys to communicate on scene. Slow down, get a set of vitals, do an assessment, give them some pain management, but certainly don't be moving them or, not treating their pain while you're doing a painful procedure. So there's a balance. And then you can start low on your medications, you can always redose it. Fentanyl is great in these patients because it's a fast onset and you can redose it more frequently. Again, our morphine is going to be a little less practical for a redosing every 15 minutes. And I think that really we should be using a whole heck of a lot more fentanyl within the system. Other questions? Yeah.
When do you use morphine over fentanyl? I mean, it seems like a lot of, give me an example, because it seems like with everything you show me here and what you like, why use morphine at all?
Good question.
Just curious.
I mean, honestly, do I really think we need it in the pre-hospital setting? No, I don't. Is it nice to have a second option, especially if you're doing a longer transport and you are busy and you can't redose every 10 minutes? Yes.
Is there something you prefer over morphine in addition to fentanyl that we could look into then?
Dilaudid?
I like that Dilaudid stuff. Yeah. Now we've talked about Dilaudid, and that brings up a whole no Dilaudid. So Bobby, in response to your question, I think for the majority of the cases, there's not really an incident where you would use morphine. I use morphine more in the ER just because I'm going to have them there for a couple of hours, and I want to make sure because my nurse can't get in there to redose that patient frequent enough to keep them comfortable. So I go for the longer acting narcotics. I use morphine, I use a lot of Dilaudid in lower doses just because it's longer acting. So I know that that patient's going to be comfortable with when my staff's tied up. But in the pre-hospital setting, it's a little different issue.
Morphine has a little bit of
You're cutting. I guess traditionally for the histamine response in a cardiac patient, right?
What?
For the histamine response we're looking for in a cardiac patient.
Did you hear what she said?
I know, but that's why I'm interested in that study.
So it was not found in the Crusade study. They only looked at NSTEMIs.
Yeah.
So in STEMI patients, there's no change in the mortality with using morphine, which is a little interesting because you think if it hurt one, it would hurt the other, right? It's essentially the same, similar pathophysiology, but I don't know. So why they found an increased mortality, they don't know. Is that clear enough?
Maybe it's because we use morphine down the line that are already nitro hasn't helped, and that's what I don't know if the study was flawed.
They looked at it with morphine being given as the initial, so aspirin followed by morphine, and then they looked at aspirin with nitro followed by morphine, and they looked at patients with just aspirin and morphine. So, and they found it in all three.
You see NSAIDs coming on to the transport agencies ever in the future?
NSAIDs?
Yeah.
Yeah, we've looked at Toradol a bit, and someone emailed me. Yeah, Travis emailed me a couple weeks ago about Toradol.
Yes, please.
Yes, please, yeah. I would be happy to look at it. I think we should look at the literature behind it and see, has it been successful in the pre-hospital setting? I'm certainly up for doing new things, but I'd like to see what the research shows with it. I tend to be a research-based person. I want to see the evidence behind it. We'd have to be careful with patients with history of bleeding ulcers, bleeding disorders, recent surgeries. Anybody who potentially could go to surgery cannot have Toradol on board because of the increased risk of bleeding. And that's the one thing that's kind of kept it out of the pre-hospital setting, is because you guys aren't able to diagnose who needs an OR versus who doesn't. And so then if we start giving a lot of Toradol, then we're potentially creating higher risk for these patients who have to go have an emergent surgical intervention.
On that, how long do they have to wait before they get that surgery?
8 to 12 hours is the effects of Toradol. So it can be pretty substantial. But I think in certain patient populations, it would be nice. It would be another tool in your guys' kit that you could use. And I'm certain, I believe it's cheap enough, but don't quote me. I haven't looked into it. So it's something, again, that Travis brought up and emailed about. We'll look at it, and it's a possibility. I just want to learn a little bit more about it in the pre-hospital setting.
It's more of that chronic usage that it's selected. You know what I mean?
Chronic usage.
The chronic pain patient that says, I'm out of my meds, I can't, and then you go, hey, do you take NSAIDs, do you do that? And
yeah.
That's when it's more chosen in a pre-hospital setting, in my experience.
I could see that. I mean, that's when I choose it more.
Yeah.
Although I will say that probably 50% of the time in the patients that I would like to use it, they have a stated allergy to it. So that's limited.
That's because they did it with the first time.
Right.
They want that narcotic. So
it
you
didn't
ask
work.
them,
Yeah.
what happens?
Other questions? Nitrous. I knew nitrous. I was waiting for it. So it is really good. It's one of the most, excuse me, I'm off night shift and words are escaping me. It's one of the more effective pre-hospital pain management. It has pretty low risk, low side effect profile. But what creates the hurdle to it is the cost of implementation of it. So it's not expensive once you have it. The actual gas itself is very, very cheap, but the equipment to get mounted within the ambulances and apparatuses, that is the extensive cost and is really the barrier to the majority of the agencies using it. So if anybody wins the lottery and they want to pay for nitrous on the ambulances, I'm happy to support that.
Snowboarders love it.
Snowboarders love it. So we have one more case. So our trauma patient, this is probably the second area where I see most interagency frustration. So you're dispatched to an MVC, you arrive on scene, there's extensive damage to the patient's vehicle, 12 inches of intrusion into the driver's side, steering wheel broken, the windshield star, and the passenger's DOA. So what do you want to do? What do you want to know?
Call a helicopter.
Call a helicopter? Okay. They'll dispatch one from Ontario, they'll send it to Twin Falls, and then they'll be here. Sorry, I should take my bias out of this.
Assess the patient first.
Assess the patient. What do you?
Status.
Mental status.
Vitals.
Vitals.
Complaints.
Complaints.
Was he the one driving?
Yes, it was the driver.
Still in a vehicle?
Yes. Still in the vehicle. Was the driver restrained?
Conscious?
Conscious. Alert and oriented. The person, place, and time doesn't really remember the events of the accident.
Restrained?
Huh?
Restrained?
Restrained. Yep.
What are his complaints?
As far as complaints that his right wrist hurts and you see an obvious deformity, complaining that his left knee hurts, you see a deformity to the distal femur. Otherwise, no complaints, but it's just screaming in pain.
What caused the collision?
Doesn't really remember bystanders, they're not really sure, they just drove upon it. C-collar? Okay, distracting injury, right?
Yes.
Okay.
So I've found that early mild sedation helps out with both your assessment and kind of reducing further injuries on these patients. So
By mild sedation, what do you mean?
well, like especially on these big wrecks where there's multiple patients, doing a little bit, if you can have contact with them, doing some iron Versed
Okay.
off the bat, because especially if they're combative and everything is going on versus trying to get a blood pressure cuff in there and hold on, I think I hear a blood pressure and so on.
So you're gonna give this patient iron fentanyl before you have a full set of vitals and before you do a primary assessment on them?
Or you're gonna do a rapid trauma assessment on them, but if you're gonna, mid-30s patient, extensive pain, their blood pressure's probably still gonna be up.
Okay. I would say, no. I would say they need blood pressure first.
So how many times, how many
charts are
times
for
do you
review.
get
Yeah. Note to self, review verdict chart.
Extrication, is trapped, and even getting a palpated blood pressure on those patients is very strong.
Strong regular radial pulse.
Yeah, I mean, it's,
Yeah, not gonna cut it. A strong radial pulse is not gonna cut it in my book. These patients need a full set of vitals to make sure that they are adequate for pain management medications. Because
so what is the fentanyl gonna do? What are you looking at, I guess, if you're gonna get fentanyl?
So if this patient has a blood pressure of 80/40 and they're altered and have distracting injuries, are you gonna be a little bit more leery with your dosing of pain medicine if you're gonna give it? Some people wouldn't even give it because technically they're significantly hypotensive and narcotics are contraindicated. But if you're gonna give a little bit of narcotics to be able to get them out of the car and get them safely transported to the trauma center, are you gonna, if they're hypotensive, are you gonna be a little bit more cautious with your pain medicine? Are you gonna give them 100 of IN fentanyl?
An example might be this time of year, sitting in a car and they're parking, and they get in a wreck, we got a 10-minute extrication. We don't really have the ability to cut their clothes off, nor would we want to because of temperature, to get the blood pressure.
You don't have to cut all their clothes off, you're cutting a sleeve. You're opening up a sleeve. And it doesn't have to be an auscultated blood pressure, it just needs to be a palpated systolic blood pressure. Document that, get a basic neuro exam, and document that and before treating these patients. I'm not saying don't treat them.
How about we just take them out of the truck and then get in the ambulance and yay, we can do stuff there.
In this patient, that's great, but we're talking more like the extrication. Somebody's going to be pinned in the vehicle for a little bit longer.
Well, venous intrusion, I think that's gonna take a minute or two.
It's gonna take a little while,
On the
right?
other side.
They're gonna.
So it's just, I kind of, I kind of agree with him. There's a point where, if I feel a good, strong radial pulse, we're still having to do a full quick head to toe. We want to worry a little bit about bleeding, but I don't think there's a reason why some intranasal fentanyl might not be a bad idea in this case. And if you follow the studies back, you're looking at a 2 to 4 point blood pressure drop on an average for the maximum end of most patients receiving fentanyl. So it's not a huge drop on top of that. So it's kind of, ideally, it would be great to have the full set of vitals. And I think if we can get a minimal set of vitals, maybe in this case, I think it should still be acceptable, kind of a.
Right. I'm not saying you need to get a temperature or BG on this guy. I'm saying you need minimum of a palpable systolic pulse and a basic mental status exam before you're giving anything that could potentially deteriorate his clinical status.
I agree with that. That's
Yes, it's gonna be, huh?
You said palpable systolic pulse.
I'm
How
sorry,
about we say
systolic blood pressure, sorry. Night shift. That's what I really like fentanyl in trauma patients. It's all we give in our trauma patients because you're right, there is very little hemodynamic effects with fentanyl, but there still is some, especially in those patients who are teetering on compensation and you take away that sympathetic drive from the stimulation of their adrenaline, and these patients will tank even with fentanyl. And so that's why and why it's in the protocols that they,
Could you say that again about the lack of hemodynamic effect in fentanyl and put that in an email and send it to Tim Ryan, please?
Everyone has different experience with it. We're not gonna pick on anybody. Everybody does it different, right?
Tim and I just, we, as close as we get to argue, we talk about it all the time, we debate it all the time.
Right. And there are studies that show very limited effects with the fentanyl. It's why I prefer fentanyl, especially in the trauma patients. Again, other reasons why I prefer fentanyl. But while it has minimal effects, it still can have effects, and that's why I really want, at minimum, systolic pressure on these patients with a basic mental status exam. I totally agree with you that a little bit of pain management is probably going to help this patient's extrication and help them be less combative and more manageable, and therefore improve your care en route to the hospital. But you need to get those basic assessments. Start low dose, especially if they're hypotensive. You can still give them pain medicine, but start low dose and realize that when they're being transported by the medics, they're going to get repeat dosing. So a lot of the frustration I hear is that, you know, they're put in the back of the ambulance and the patient's still screaming out in pain, and I don't understand why they didn't get more pain medicine. Well, they are going to get more pain medicine. It's just going to be after that ambulance has left your line of sight. They get redosed en route to the hospital. I have looked at those charts. I have made sure that we are redosing when patients aren't having adequate pain control, and they are getting redosed and they are getting improvement of pain management. Okay, but they're getting it done safely in smaller, more frequent increments in the patients who have a higher risk for having compromise. Yeah.
You know, there's a part of me that, you know, you've got 12 inches of intrusion, you have a broken steering wheel, your windshield is damaged, you wasn't restrained, and you've got a dead passenger. I mean, there's this part of me that really just wants to get this person out and do a complete assessment before I start giving them pain management. You know, do I have evidence of a liver lack or a spleen issue? Because then you know,
You're a little more hesitant.
I'm a lot more hesitant. And
As you should be.
so I guess these are people that I kind of want out of the vehicle, and I'm all for the group. You know, we all need to be involved, and we all need to make that decision together. And I think it's hard sometimes to make these decisions when people are in the vehicle, especially if it's a short extrication time. If it's a longer extrication time, I think, you know, we need to take that into consideration. Man, it just makes me nervous.
The goal of this case was to have it be a prolonged extrication. I think I must say I do agree with you on the patients who you're going to be able to extricate within a couple of minutes. That getting them out and taking a look is ideal, because one person can be cutting while the other's getting the blood pressure, while the other one's doing a brief mental status exam. It doesn't have to be a step by step by step. You guys can all work. I mean, how many providers are on scene with this patient? Somebody can do one thing. It can be done in a matter of 30 seconds, and a good decision can be made.
And what usually happens with us is our medic is going to go interior, if they can, and start that process, start assessing the patient and trying to relay that information to the crews.
Yeah.
Exactly. Even though we don't technically are not supposed to make anecdotal decisions, if we have had patients over and over again, and when we do give fentanyl and then our first pressure is like 70/40 and we're like, really? We tend to not do that as much, do the pain control, because they're on that verge. You inside the vehicle, oh yeah, he's got radial pulse, you know, and then you're like, and I'm sorry, I talked with you.
Was there anything?
And then we take pressures, and they're going like this, and we're going like that with the fluids.
Right.
Then we tend to make those decisions because we have the patient a little bit longer than 5 minutes.
Right. Exactly, and that's where there's a middle ground, and that's what we're trying to find. We're trying to make sure that we're not rushing in, just giving pain medicine and then doing our basic assessment, but we also want to make sure that the patients are receiving adequate pain management, one, for their safety, your safety, and for just, if it were your family, what would you want, kind of thing. So there's a middle ground, there's a safe way to do it. Sometimes we're a little more aggressive, sometimes we're a little less aggressive, and the goal is to meet in the middle. But you're right, you arrive on scene and you give someone a big dose of iron fentanyl, and then you get your first pressure and it's 70. It's like, well, were they 70 before that fentanyl, or were they 70 after that fentanyl? Because that's going to affect further dosing, right? Like if you get someone and their initial pressure is 110 systolic, and you give them 50 of fentanyl and their pressure drops to 80, well, are you going to give them another 50 of fentanyl? No, you're going to probably hold off or give them a small 25 micrograms if they need it on the way to the hospital, and you're going to be very leery about it, but you don't know that patient's response to that initial dose if you don't have a starting point. Casey.
So
I've heard two different things. I think we're talking about two different things. Like for this patient especially versus like the grandma who fell between the toilet. And one is pain management versus sedation, right? If we're worried about trying to sedate a patient so we can extricate him more easily, I get pretty concerned about that, especially for this guy, because there's a lot of force involved. He killed a passenger, broke his steering wheel and whatnot. And so that pain response that he's experiencing that's making him tachycardic but still hypotensive, maybe the only thing keeping him alive at that point. You know?
These patients do have a strong sympathetic drive with their adrenaline. From the accident, you take the fentanyl and you blunt that response and they can tank very quickly. It's very true. So that's where we're saying, like, get the basic assessment. Yes, still keep pain management in the back of your mind, but it shouldn't be your first priority. It's important, but assessing this patient is your first priority.
What about, I mean, working on maybe creating trends? I mean, trends are big on vitals. We want to see a trend. So, you know, what's 5 minutes on this guy? Wait, do another blood pressure. Get another set of, his pulse rate and see where he's going before we push that med. I mean, I understand that we want to medicate, but at the same time, like Casey said, we need to see where he's going.
And there's not one right answer, and every situation is different. And again, I say this over and over again, the protocols are written to be gray so that it gives you guys the ability to use your clinical decision making on scene and take every different clinical situation into account and use your knowledge and your skills to do what's best for that patient. So sometimes what's best for that patient is difficult, having them be uncomfortable, but making sure that they're stable and safe before they receive that medication. Sometimes what's best for them is that that they're safe and they have a good blood pressure, and getting them some pain medicine and making things a little more comfortable for them. So the goal is a group effort, a team effort, communication on scene, and finding that middle ground, making sure that we're keeping it in the back of our mind. Yes, it is a priority. We need to make sure it's a priority, but we need to do it safely after some basic things have been obtained.
No, honestly, on this guy, potentially RSIing him is going to be a higher priority for me than managing what pain he may have.
Right, depending on how combative or altered he is, or what is he alert and oriented and just screaming because of his broken femur, or is he screaming because he has a huge head bleed? Right, exactly.
This is gonna be unpopular, but one of the things you have to remember is that sedation and pain medicine does not save lives. And as soon as you give this guy something and he collapses completely and you haven't even started your extrication yet, because that was your priority as you approached the guy because he was screaming, to shut him up, make him more comfortable, and he completely collapses at that point, you're done. He's done. Because you did it. So you gotta think about that stuff. Pain medicine makes us comfortable, makes the patient comfortable. Sometimes it's gonna be a painful event.
So here's the goal with the whole, summary first. So good assessment, basic, systolic blood pressure, mental status exam. Remember your basic techniques first. It's not, this applies to the trauma patients as well, especially with the patients who have isolated injury, ankle fractures, wrist fractures, monkey bars are a good culprit, trampolines, grandma who fell. Fentanyl's better in renal insufficiency, less hemodynamic instability. There's a couple studies that show it's better if the patient has an underlying history of asthma or bronchospasms, but it's very minimal. Fentanyl, consider it first line because the peak effect is what? 2.5. How long does it last?
Half to 1 hour.
Half to 1 hour, yep. Whereas what's the peak of morphine? And what's the duration? 3 to 4 hours. So faster onset, you're going to get better pain management when you're going to be moved. I mean, let's be honest, you guys aren't going to wait around 15 minutes to move a patient, right? So giving them morphine, you might as well give them a saline bolus. Morphine, longer duration of action, but slower onset. Sometimes saline might work. And the biggest thing is the team approach. So here's the goal, you guys skipping barefoot through fields of wildflowers together, right? Everybody hand in hand, happy family, right? I'm holding out for it. Questions, comments?
I have a question. Right now the protocols for chest pain. Fentanyl's only ordered, or it's only indicated if they're allergic to morphine. Is that gonna be something we might see as a change?
Yeah, we could easily change that. Dave would love to change that. He loves changing protocols. We will.
We can change it.
We'll put fentanyl as an option for chest pain.
Especially with like that study that you showed with morphine.
Morphine's still preferential there though, right? For the STEMI patient.
Not either one. There's not one better than the other.
Okay.
I would say what's best for that patient is an aspirin and a gas pedal.
Right.
No, a diesel pedal.
They don't say
Sorry.
gas.
a
Yeah, you
diesel
put, you
pedal.
put gas in those and they cost a lot of money.
It's funny how you gotta worry about those things now, huh?
Other questions? Sorry, we went a little bit over. I know it's a lot of your guys' day off. Thanks for coming in. If there's specific cases that come up and you say, what do you think about this? What about that? I had some concerns with how this was done, how that was done. Please email them to me so that we can look at both sides and we can get it worked out and we can start to see trends so that we can work on getting everyone on the same page. Yeah.
And how about we talk afterwards if there's an issue?
That'd be great. And I find that that's happening quite frequently.
Call me.
All right, guys, thanks for coming.
Thank you.
Thank you.
Really?
Right, that guy.